That I'll check, ma'am. I don't remember exactly.
So green is something benign. Okay. Red is warranting. Yeah, it is malignant. Okay, suspicious. Yellow is in between.
Okay. So elastography, madam, is it depends on the elasticity of the tissue on the basis
It depends on compressibility of the tissue.
compressibility that benign tissues have less fibrosis, so are more compressible, and malignant tissues have more fibrosis. So they are so when they give that high energy ultrasound pulse, then based on the compressibility of that pulse, I guess, ma'am, they decode it into red, green, and yellow according to the fibrosis.
Correct. That's correct. Okay, so that is them. In case they ask you, that is minimum that you should know. Okay. Any other investigation? I think we have covered everything. Okay. So coming to this one, what? Next one. What do you want to do? Core biopsy you have done. Okay, your patient is 75. You told, no? चलो ER/PR पॉजिटिव है, HER2 नेगेटिव है, K 67 10% है. Okay, and no evidence of distant metastasis. So T4B lesion N0. N0.
Yes, sir.
It was N0, right? So
yes.
T4B N0. No much comorbid she has. So what do you want to do?
So we will plan for neoadjuvant chemotherapy, then as reassessment and further plan.
Patient se bolna.
Yes, ma'am.
You have to discuss with patient, no?
Yes, ma'am. We will discuss patients or available treatment options, and
you won't tell it is ER/PR positive. So it is T4B.
Yes.
Okay, how will be the response?
Response will be not that good, but then.
So you need to explain all those facts to patient.
Yes.
Okay.
Ma'am. Yes. Ma'am.
So, okay, I am your patient. Tell what you want to tell. See, now we have discussed the diagnosis. To confirm the diagnosis, to stage the disease is over. Okay. Now you are discussing with me.
Yes. Ma'am.
To manage. Okay. So
yes.
Tell me all the options.
So
I am your patient.
Okay, ma'am. So you are having stage 3B, like T4N0 M0 ER hormone receptor positive breast cancer. So for that, our next treatment plan will be, we will undergo for neoadjuvant chemotherapy. Though the response might not be that good in terms of downsizing the tumor, but it will decrease the chances of distant mets and local recurrence as well. And after the response, we can have two types of surgeries. Like if the response is good, we can plan for breast conservation, or we will go for modified radical mastectomy. And if their response is not that good or the tumor progresses, then during the chemotherapy, we can plan for MRM or like radiation if needed in some cases, or even for palliative care, like that.
Okay, doctor. I am afraid of chemo. Okay, so T4B lesion. Okay.
Yes, ma'am.
I'm reminding you, it's not focal T4B, it is diffuse T4B, right?
Okay, ma'am.
So, would you prefer BCS? Or what do you want to do?
For diffuse?
Yeah, diffuse BCS. Diffuse T4B.
No, ma'am. For diffuse, like before NACT, na?
Yeah, okay, first. Okay, if you are doing NACT, okay, yes. If it is a diffuse T4B, not yes. Focal T4B, okay?
Yes, ma'am.
Your patient is asking for BCS.
Yes, ma'am.
What will you tell her?
So, if the response is good and the
for diffuse T4B, ma'am, we cannot do BCS.
We can do.
That's what I'm trying to tell him.
In inflammatory, we can't. But if response is there, ma'am, we can't we do?
Like, no, T4B diffuse, you always have chance of getting a recurrence. Okay. So even if the response is good, and especially in hormone positive, okay, don't decide on doing a BCS. Okay. Diffuse T4B, you explain. See, patient may not agree. That is a second different thing. Okay, but the chances of recurrence are more in especially long-term recurrences. No, all hormone positive, they recur even after 10 to 15 years.
So
unlike TNBC, which come in.
Yes.
Yeah, it is better not to do, because you don't know the micromets when they might have spread. So the recurrence chances of recurrence will be more if I preserve the breast. You should explain them. Okay.
Yes.
If it is a focal T4B, only this one, then you can take a chance. That too, better not if it is a hormone positive. Okay. So they have delayed recurrences. Okay. And the poor response to chemotherapy. Okay.
Yes.
So yeah. So now, what are the studies, doctor? Like, why you want to do NACT? What are your intentions in giving an NACT?
So, ma'am, one more doubt. You were saying like hormone receptor positive focal disease post NACT, you can take the chance of BCS, saying that there is late recurrence. So if it is TNBC, they can recur early, na? That is more dangerous than late recurrence.
TNBC response rate is very great.
Good.
But recurrence is also...
No, that's what I'm telling. You have to explain. Ideally, T4B is not preferred for PCS. Okay. But if it is focal, patient is insisting, you have to explain this will be response to chemotherapy. Okay. Generally, TNBCs, even micrometastasis, whatever is there, will be treated by chemotherapy.
Yeah.
But response in hormone receptor positive is bad. Okay. So they will miss. They are missed by chemotherapy. So there are more chances of recurrence in a hormone receptor positive with a T4B lesion compared to TNBC with a T4B lesion. Okay. So when you preserve the breast. So ideally, in case of T4B, don't take a chance. Okay. So if they are agreeing for mastectomy, that is better. Okay. If they are insisting, if it is hormone receptor positive, you should be still more careful. Okay. So there will be high chances.
Yes.
See, we are talking about loco-regional recurrence, not distant recurrence. Okay. Where does TNBC fail, Mohan?
Systemic failure.
Systemic failure. Okay. So the hormone receptor positives fail more so often in loco-regional compared to systemic. Yeah, loco-regional nodes also. Okay. So yeah. Then where were we? Yeah. So BCS, tell me why NACT? Tell me 4 indications, 4 intentions behind giving NACT.
So first will be, it will cover them, it will reduce or cover the chances of micrometastasis. Second, it may downstage the tumor. And third thing, if patient is opting or willing for BCS, if the response is there, we can plan for BCS after NACT. And
yes.
Fourth is, like, for some cases it can provide extra time for like hereditary some testing
or assessing
or like
the biology of the disease.
Genetic testing.
Yes, okay. Prognostication also. It can be a prognosticator as well, depending on the response.
Okay. Correct. So what are the responses to NACT in hormone receptor positive, in TNBC, in the HER2 positive? And tell me, do triple positive respond better or HER2 rich respond better?
TNBC.
So
HER2 rich responding
arrange
better.
them in, if you are to arrange these subtypes based on response to chemotherapy, how do you arrange them in descending order?
So TNBC, HER2, hormone receptor positive.
I gave you 5, no? Hormone receptor positive,
also.
HER2 rich.
Hormone receptor positive will be last, ma'am. Like TNBC, maximum response can be seen there. HER2 is also near about TNBC. Then
triple positive, then last HER2 positive
will be third one, and then fourth will be hormone receptor only.
And fifth,
And in that
what
also,
option you given, ma'am?
luminal
Are
B
you sure?
Fifth
Are
option?
you sure?
Sorry, ma'am?
No, HER2 rich. Okay.
Yes.
Triple positive. TNBC. Hormone receptor. No, 4 only. Tell. HER2 or TNBC?
Yes.
TNBC.
TNBC.
Trastuzumab, pertuzumab. What was the addition with dual agent? What was the response?
Somewhere around 50 to 55%.
No.
60%.
70.
PCR.
What is the trial?
70
What is,
to
Trifina trial.
what is the trial?
Trifina.
100%.
Trifina.
Neosphere and
What is it?
Trifina. Neosphere and Trifina.
Yeah. Neosphere is neoadjuvant. Okay.
Yes,
So,
yes.
trifina is adjuvant. What did it tell? How much percentage?
Response will be
70%,
like
ma'am.
70% and PCR around.
It is 63%. Okay. With a dual agent. Okay.
PCR or
So,
PCR.
PCR.
PCR?
Yes. PCR
What
is
data we are
63%.
saying it's of single agent trastuzumab?
Tras2 plus PER2.
Hey,
Both.
ma'am, jo previously what Rakesh said, that is true with the single agent trastuzumab, but after
Yeah, yeah.
pertuzumab,
It is
PCR rate
63.
increased.
Yeah, 50%, then 63% it has gone up. Okay. So with TNBC, it is, what is PCR?
45%, I remember.
No, 50 to 60% around. Maybe we can say 55%.
So was it more for HER2 or was it more for TNBC?
Before it was more, but then dual, after dual, as you told, ma'am, for R2 it is more.
So it is for TNBC के लिए 40 to 45 है. Okay. For single agent, it is 45 to 50, 63%, around 60 to 64%. 63 they have shown.
But ma'am,
dual
after
agent.
keynote 522, I think PCR rate for DNBC.
That is pembro. Yeah, that is different.
Pembrolizumab.
Pembrolizumab addition is different. Okay. So we are talking about this only targeted agents. Then we will discuss the PDL one. Okay. Then what about hormone receptor positive? How much was it?
10 to 30.
Like for luminal.
No, not 30. 8 to 10%.
8 to 10. Yes.
So, yeah, do HER2 do better or triple positive do better?
HER2. Like for response?
HER2 rich do better or triple positive do better?
Response or survival in terms of survival? NACT?
No, I'm asking about PCR only.
PCR R2 rich will do better.
HER2 with dual agent do better than TNBC.
So HER2 rich do better compared to triple positive. Okay, wherever positive is there, PCR is less. Okay, same applies here. Whatever we discussed in PET, no, the rapidly dividing chemotherapy also same principle. So they don't have much of PCR. Okay, so can you tell me something about types of PCR? Like what all types you know?
Types of PCR.
What is PCR?
Pathological complete response.
What is CCR?
Clinical complete response.
So what are types of PCR?
Types of PCR, like different gradings.
Radiological complete response, clinical complete response,
on
pathological complete response.
No, PCR is on based on
PCR might be in breast, PCR might be in breast and nodes, okay? Or PCR might be complete.
But ma'am, in this we are considering PCR only when pathological, no residual disease in the breast and as long as with along with the lymph node. So then only we will say complete PCR.
There are definitions, okay? German PCR, okay? Total PCR or breast PCR, okay? So breast PCR is something that we don't see there are two components again. We don't see invasive, we don't see in situ. Okay. As per the definition that is followed now, when we don't see invasive component either in the breast or in the nodes, that is total PCR. Okay. We can still see in situ component, but this is an exception when it comes to TNBC. TNBC PCR is defined as PCR in which we don't see either neither invasive nor in situ. Okay. You should not see in situ component also. Then only it is PCR for TNBC. Only for TNBC. Rest of the subtypes, invasive, if it is not there, then it is considered as PCR. Okay. If it is not there in the nodes, then it is total PCR. Breast and nodes. Okay.
Okay.
So German PCR is there. Okay. So German PCR is absence of invasive or in situ component and absence of any disease in the nodes. So complete it is. Okay. Got this?
Yes.
These are definitions. Okay. So yeah. So anything you know for response assessment?
Response resist 1.1.
I'm asking for pathology.
One W.
Residual disease.
RCB.
Residual cancer burden.
RCB.
Yeah. What is it? RCB? Gradings?
0, 1, 2, 3.
Yeah. What are those? What is the range?
Less than 33, 33 to 66, greater than 66.
No.
Necrosis means
It's a number.
components are there.
Type 1 to, I mean, grade 1 to 3 is
Yes,
there. One
yes.
is
There are
subdivided into-
components. What does RCB mean? It says lymph nodes. Okay, the status of the lymph nodes as well as the main lesion. Okay, so it is absence of presence of any abnormal cells either in the lymph nodes or in the primary lesion. Okay, so then RCB is anyone range 1.33. 1.33 to?
Not aware, ma'am. भूल गया.
1.33 to 2.36.
क्वेश्चन मैडम क्या है? मैं थोड़ा नहीं समझा.
RCB 1, 2, 3.
Okay.
So क्या है वो? Response cancer burden, residual cancer burden. What is the range which you said? 0, 1, 2. Sorry, I told 2, 3. No, sorry. So 0 to 1.33, 1.33 to 2.37, more than 2.37. Okay. So this is the residual cancer burden. Then any other scoring pathological for cancer burden?
Muir-Penn cancer.
Miller-Penn. Yeah. Can you tell what is Miller-Penn?
What is it, ma'am?
Miller-Penn.
Okay.
0 to 5. I mean 1 to 5. Okay. So you people read and tell me.
Yeah, we will do that.
Okay. It is based on how much amount of like in rectum there is fibrosis grading, not TRG grading.
Residual.
Also it is like Miller-Penn is based on the number of residual cells present. Okay. So yeah, complete response and like no response at all from that 1 to 5. Okay. Yeah. So next week you'll tell me this Miller-Penn. Yeah. Coming to NSCT versus upfront, what were the studies which told NSCT beneficial? Just name of studies and what is the proof?
NSAVP B27, ma'am. 18 and 27. 18 4 AC and 27 was 4 AC followed by Texans.
That's all. Okay. So what did it tell?
So
how much was the response with chemotherapy? Like, and was there any overall survival benefit or disease-free survival benefit?
no over survival benefit was there, but then response was there, ma'am. I think 20 to 30% response was there. I'm not remembering exactly.
Was there no overall survival benefit?
LR difference like for BCS 10% and for mastectomy 12% something was there.
What are you telling? 10, 12 recurrence?
Local recurrence.
No, I'm not asking. See, don't combine both. Okay. BCS versus MRM is different. I'm asking you the use of NACT.
Yes.
Why is NACT? It has become standard of care, right?
Yes.
So they're giving NACT prior to in some subtypes. So it has become standard of care. If it has become standard of care, what has it changed? How much was the change? Anyone else?
Like at one Tata study, I remember they showed response around 80% and BCS in 30%.
NSABP 18 or 27 के बारे में बोल. AC and Taxol, how much benefit they have added? 54. You people will read and tell. I can tell, but you'll not read. Okay. Yes. Homework. Milapine, NSABP 18 and 27. Okay. So yeah. So AC you told, AC Taxol you told. Okay. Then So can you tell me like what are the regimens of giving Taxols? So I mean, how frequently can you give?
3 weekly and 2 weekly. Dose dense will be 2 weekly.
Is there any weekly?
Yes, ma'am.
Weekly, yes.
So was there any difference?
No. Dosage.
Was there any difference with dose dense and what was the study?
Dose dense was non-inferior to 3 weekly.
Dose dense was non-inferior or superior?
Superior
to 3 weekly.
So some in breast, few trials are very important. Okay.
Yes, ma'am.
So few trials are important. Some numericals are important in breast. Okay. Because breast and head neck, you can't take a chance. You should know at least name and what is there's a table viva that is on recent investigations. Okay. So somebody's mic is open. Yes. Please mute yourself. No. Yeah. So in table viva you have a one session only on trials. Okay. They'll ask you one trial. Okay. So and some recent investigation, like advances. Okay. Something like robotic TORS or like that. So that in that table viva, they will ask you standard only. They won't go and ask some kind of they will not ask fire trial mein kitna hua tha. Ye sab nahi puchenge. But standard like breast trials, SLNB trials mainly, BCS MRM versus MRM, NACT trials. Okay, these are and now immunotherapy has come. So breast mein ye sab are important. Okay, the numericals as well as conclusions, at least conclusions and few how much was the benefit, because they are treatment changing trials. So they have become standard of care, these treatments. So you should remember few trials. Okay, I'll send you some PPT. They are old trials only, but they have given the conclusions and they have given the numbers. So remember that. Okay, so I'll send you that PPT. Okay. Once you people read, then I think that questions will be useful. Okay, we'll discuss in next class about the trials then. All of you should read. Okay.
Okay.
So, okay. Do you know about anything about, now Soumyata told, pembrolizumab.
Yes, ma'am.
So what is it, pembrolizumab?
So it is like pembrolizumab is part of immunotherapy, ma'am. Checkpoint inhibitors we give.
Okay.
Based on for different solid organ cancers based on the PD-1 expressions.
Okay.
And we are also
so
using...
it has been approved for which type of subtype of breast cancer as neoadjuvant treatment?
TNBC, ma'am, based on keynote 522.
Yeah. So ongoing trials are there for hormone positive, but not approved. Okay.
Yes.
So now you tell me this. You told me pembrolizumab. Okay. AC Taxol. Okay. Do you know the doses?
Exact doses I don't remember. I'll read and tell.
Anyone else?
Adriamycin 60, cyclosporin 600 kg per mg per meter square.
Okay. Taxol.
Paclitaxel 75 mg meter per weekly, like 180 mg per meter square 3 weekly.
Any other regimens are there other than this AC Taxol for TNBC used in specific?
Platinum we can add.
Yes.
Carboplatin? Yeah.
Yes.
Area under curve 5-6.
Why it is there AUC? Why it is special? For all these drugs, no, they have given based on body surface area. Why area under curve for carboplatin?
Nephrotoxic.
Creatine clearance maybe might cause
Based on Calvert formula.
These are also causing same thing. Cisplatin is also causing nephrotoxicity, neuropathies. Why carboplatin is so special? You'll find it. It is something related to. Yeah, tell.
This is I don't know at all.
Okay. So, okay, I'll give you a clue, but you should tell me exact word. Okay, next week. So it is related to the toxicity in relation to the dose. So the therapeutic window is less. Okay. So with minimum increase in dose, there will be much increase in toxicity. Okay. Find out what exactly they call this. Okay. So that's why carboplatin.
So, sorry, ma'am, the response criteria that you were telling, could you please tell that again? One was the RCB, the other one was Milapen.
That I sent one paper, na. They have compared both criteria.
Okay. I'll check.
MILLER PAYNE.
Miller-Pain. Okay. Okay. So I was asking, yeah. So resist criteria, anyone knows? What is resist? 1.1 is one that is followed. Okay.
Yes.
You tell me what is it.
So
and in breast, what is the minimum to call it a response?
Up to partial response, complete or partial response.
Complete partial. Okay, you tell me first resist criteria, then we will tell what is response in breast specifically.
Okay, ma'am. So stable disease will be when response is less than 30%, or like response is less than 30, or if progression is there, it is less than 20. If more than 20, it will be progressive disease, and more than 30 will be partial response, and if it is complete response, then CR. No disease is left, then complete response.
30% decrease, 20% increase.
Yes, ma'am. Stable. 30% to 20 stable, more than that.
And appearance of any new nodules.
Yes. New lesions. Yes, progress.
And nodes also they have given, no? Size.
Yes, ma'am.
Okay.
Yes.
Shortest diameter, short axis diameter.
Yes,
okay. So, yeah. So in breast specifically, anything less than 50% is considered as no response. Okay. So anything above 50% is only considered as response. Okay. So yeah. Then this is about response assessment, NACT, uses of NACT, and the NACT subtypes. So yeah. Other than that, can you use neoadjuvant hormonal therapy?
Yes, ma'am. In post-menopausal early stage lesion, we can use.
Everyone?
Greater than 70 years.
What is the response with NAHT?
Similar to that of chemotherapy, but over a period of 6 months.
It is also low risk on oncotype DX. Then in like post-menopausal early T1, T2, N0 lesions, we can plan them.
There are specific indications for NAHT. Elderly, who cannot tolerate. Okay.
Yes.
So frail patients will be there, no? So they for them only use. And it starts in
CAL-GB some trial is there, na? They have
Yeah.
evaluated in
CAL-GB,
elderly patient. We
above
can
70.
1071 and
About 70 years. It is only hormonal therapy can be given. Okay, radiation can be omitted. Okay, that is CALGB. So yeah, one more. What was I asking? Yeah. So NAHT, when do hormones start to act? What is the minimum time?
And then brightness is the trial, na, for carboplatin and TNBC.
Yes.
Brightness is the trial. Correct. So I'll send you a PPT. Okay. That will give at least the names and the numbers. Okay. So the conclusions. I have a couple of PPTs which are good. They're old PPTs, but there's like standard trials will all be there. Okay. Maybe off late trials will not be there. Okay. But the standard ones are there. So you should remember that. Here and ovary also. Okay. Ovary also you should remember trials. Name at least, name and conclusion what they have drawn. So ovary maybe NACT, there are only 3, no? NACT versus upfront surgery. So MRC chorus, okay, Scorpion trial.
Scorpion
Yeah. So these are the
they
things
said
that you should
morbidity is less, but overall survival is same in interval debulking setting as compared
It is non-inferior. That's it. Not superior. It is non-inferior.
But after adding HIPEC intermediate, they have better OS in OV HIPEC.
Yeah, but only that Lim et al. Study has shown benefit with HIPEC.
Lim et al. का तो upfront
interval का भी है interval. Wander and Lim 2 are there, I think.
Wander et al. Has shown more than 100 months. So 104
et al. Is OV HIPEC only.
104 months it has shown. So anyways, coming back to breast. Okay. So we have discussed NACT. Then can you tell me dose dense? What do you mean by dose dense?
We are giving 2 weekly in place of 3 weekly. That.
What you are giving? Same dose or increased dose?
Increased
I think
dose.
same dose.
What is dose dense? What is dose?
Increased dose, na ma'am?
No, the total dose remains the same. The
total dose is the same. Frequency is more short frequency. Dose intense means the dose increases. Okay. So dose dense has shown benefit. That's why dose dense is followed. Okay. So then what is the problem with dose dense?
Toxicity,
and
tolerability. Not everyone will tolerate. Okay.
Yes.
So yeah. So we'll discuss about the side effects of chemotherapy later. Okay. Let us touch on a few points on surgery. Okay. 10:47. Na? Is it okay up to 11:50? Is it fine?
For
or
us is
if
fine.
you people are saturated,
presenter sleeps early, ma'am. Presenter sleep early. We are night.
It's okay, ma'am. No problem.
No. Okay, we'll discuss only up to 11. Okay, fine. Because you people had some other class, no, today. So I don't want to. It should not go above your head. Yeah. Whatever we spend time on, it should be fruitful. Okay.
We learn.
Even if we spend half an hour.
Yeah. You teach so well, so we learn. No problem. We can.
Nothing. Okay. Then, what are the drugs and what are the side effects? देख बेसिक बोलो, ज्यादा कुछ नहीं पूछूंगी.
Anthracycline and trastuzumab both are cardiotoxic.
Adriamycin. Adriamycin belongs to
cardiotoxicity.
So main cardiotoxicity. Anything you know about types of cardiotoxicity? What is type 1? What is type 2?
फाइब्रोसिस एंड उस पर डिपेंड मायोसाइट्स हिस्टोपैथोलॉजी में डिफरेंट होता है वो
Something is dose dependent and directly acting on
myocytes
directly acting on the heart muscles. Okay, dose dependent. Okay, something is type 2 is not indirectly acting. Okay, like something potassium कम कर देगा तो contractility कम होगा ऐसे तो ऐसा. So indirect action is type 2. Okay, it's not dose dependent. Okay, dose independent. So read about that. And what is the drug which is given to reverse the cardiotoxicity?
R से है शायद
नहीं F से है
फैबॉक्स ने टैट कुछ टैट है बताऊंगी मैम नेक्स्ट
what anti gout that is.
ओके मैम बताती हूँ नेक्स्ट में बताती हूँ
ठीक है मैं ही बोल देती हूँ फेरिमोडेक्स्ट्रिन. ओके so iron chelating agent it is. Okay, so you should know the dose for each anthracycline, like adriamycin ka kitna hai. Okay, so what is the type of cardiotoxicity that is caused by trastuzumab, and in what is difference between the cardiotoxicity that is caused by trastuzumab and what is the difference in adriamycin? Okay, which is reversible?
Trastuzumab.
Correct. Trastuzumab is reversible. Okay. So that's why before giving each trastuzumab, they'll see echo and all. Okay. So they will skip one cycle so that they whatever damage has occurred that reverses. Okay. That is not possible in adriamycin. Okay. So 900 mg and 450 mg. These are the toxic doses for adriamycin and what is the other?
ट्रांसटूजोमैब
No. Trastuzumab नहीं. Trastuzumab का डोज कितना है वैसे? Something is loading dose, something is continuation. What is
Loading is if you are giving 3 weekly, then loading is 8 milligram per kg, and then maintenance is 6 milligram per kg.
Yes, correct. If you are giving 2 weekly,
2 weekly में शायद मैडम 4 and 2 है. 4 milligram.
Correct.
4 and 2.
4 and 2. 4 and 2. Correct.
प्रताप is rocking.
What is pertuzumab?
Pertuzumab is also anti-HER2 monoclonal.
वो नहीं रे, डोज पूछ रही हूँ.
Dose you don't know. Dose you will read and tell.
So many homeworks, huh? Okay, fine. And what is the dose of? See, what I'm telling is cardiotoxic dose. Okay, 450. But at once, if you give no, so that is the highest dose you can give. Okay, in adriamycin. Okay, so yeah, so ferimodextron is the chelating agent that is used. And in pertuzumab, 840 is loading dose. Okay, 420 is continuation over 3 weeks. Okay, how do you give pertuzumab? Subcutaneous nahi. When will you what drug you will give subcutaneous?
Oral है क्या ये? Oral.
नहीं.
injectable है.
So trastuzumab, how do you give?
IV. सबक्यूटेनियस फॉर्म आया है मैम पर
क्वेश्चन नहीं हुआ क्या?
हाँ कहाँ IV देते हैं ना मैम
ट्रास्टुजुमाब तो IV है
पर
trastuzumab is IV, pertuzumab is IV. Okay,
one new form came.
एक बात करो please.
Tresgo, which is combination of pertuzumab and trastuzumab, okay, has come as subcutaneous. Okay, combination. Okay, individually pertuzumab or trastuzumab are IV, right?
Okay.
Okay, ma'am.
You'll remember? Okay.
Yes, ma'am.
All are given over 90 minutes. Okay. Trastuzumab over 90 minutes and pertuzumab over 60 minutes. Okay.
So, ma'am, when
Then,
dual blocker, when they are giving, so they are using
they
in
can
a.
give Fesgo, yeah, which is combination. They can give it as subcutaneous, but it is costly. Okay. One vial costs you around 80, I think. 80,000. Okay. This is some 50 or 56.
No, but when they are giving in IV form, so matlab, is there any issue कि we can give back to back or some? This I think should
What?
ask
Back
medical
to back?
onco. 90 minutes ट्रांटोजोमैब खत्म किया फिर 90 मिनट पर्टुजोमैब खत्म किया वैसे देंगे कि उसके बीच में कुछ गैप होना चाहिए या पता
I
नहीं
think it is given continuously because Fesgo as such is given as combination once only, no? So I think it will be continuous, but you ask a medical oncologist. I think it is continuous. Okay.
There are endless in between.
पूछना
this for
पड़ेगा ये
hydration.
पूछना पड़ेगा
Okay, what is the commonest side effect of HER2? Okay, you told cardiotoxicity. Then what are the this Fesco has this reactions also, okay? Anaphylactic reactions. You should be very careful when you're giving a subcutaneous dose. And but toxicity is less. Okay, adverse effects are less because it's through subcutaneous route. But adverse effects are less than IV route. It is costly. Then what else? What is the side effect of adriamycin? Cisplatin, cyclophosphamide. Sorry.
Hemorrhagic cystitis.
What?
Hemorrhagic cystitis.
Hemorrhagic and bone marrow.
Okay. What will you give to prevent that?
Mesna.
Okay. So whatever drugs we are talking about, just know which group they belong. Okay. Right?
Okay.
And carboplatin, compare it to carboplatin and cisplatin. Okay. So what is the carboplatin better with? And what is the carboplatin worse with? Which side effect?
Less toxicity, I think.
Nephrotoxicity.
cisplatin is more nephrotoxic
Phototoxicity is not there in carboplatin.
So carboplatin has less neuropathic effects, okay, but it has more myelosuppression, okay. So then what carboplatin dose AUC?
2 area under curve 2
Two.
Any difference with the ovary?
5.
5 to
Yeah,
6.
it is 4 to 5 there. Okay. Yeah, 4 to 5.
Carbo is 5.
Sorry.
Yeah, ma'am. Carbo is 5x.
Yeah. So then paclitaxel. What is the most common side effect?
neuropathy
Peripheral neuropathy.
Peripheral neuropathy.
What are taxins like? What do they cause other than neuropathies?
hand foot mouth syndrome में 5FU के साथ जाता हूँ
What is the? How do they act? Taxins.
DNA
So what do they cause?
Microtubule.
Yeah.
microtubule
So
inhibitor
what do they cause? If they are damaging DNA and causing decrease in cells or what do they cause?
Pancytopenia.
myelosuppression
Yeah, myelosuppression.
Myelosuppression.
Okay. So right. So you should know dose of what they give. Okay, and what are the most common side effects, and how many cycles you give?
4 cycle of XV followed by 4 taxane
Okay. If you give it weekly, how many taxanes? How many doses you give?
12.
12. Okay. 9 weekly is also there. It depends on the risk. Okay. If they are of low risk, 9-weekly paclitaxel also they can. Okay, then what about yeah, that's about most commonly used drugs. Pembrolizumab ka dose kya hai?
200 mg.
And
200 mg. 200
yeah,
mg.
what is the trial which told pembrolizumab can be used in neoadjuvant setting in TNBC?
Keynote 522.
Keynote 522.
Okay. Any other drugs you know which are under studies other than pembrolizumab?
Atezolizumab.
So okay, let's just discuss the names what they have given for this. Keynote is for pembrolizumab, right? Okay. So what nivolumab, what it is?
Checkmate.
Checkmate. Okay. Then for atezolizumab?
I am power.
I am brave, I am power,
I
power
am.
brave.
Yeah, IMP, impassion, empower. Okay. So yeah. So these are the most commonly 3 drugs which will be used. Nivolumab is under study. Okay. Most commonly it is approved for GI, this one, but they are studying in this also. Okay. Then anything. Now you tell me something. Something else. Some other drugs have come into use for hormone receptor positive incomplete. I mean
CDK4/6
pathological complete
inhibitor.
response.
CDK4/6.
Yes. So what are those drugs?
Ribociclib, abemaciclib.
Abemaciclib, ribociclib.
एक और
Abemaciclib, ribociclib, palbociclib.
हाँ.
Correct?
Yes.
First, ribociclib results are better than other cyclib.
Okay. Can you tell me the names? Do you remember in metastatic setting only? What are the names for palbociclib?
Palbo.
Palbo is?
Palas.
Palacia.
Paloma. Okay. Paloma is for palbociclib. What is for ribociclib?
Monarch.
Mona Lisa. Mona Lisa is for ribociclib. Okay. What is for abemaciclib?
Abema is monarch.
Monarch. Yeah, monarch. And monarch E has come. Okay. So, yeah, these are the CDK4. Anything else you can use for in metastatic setting?
Fulvestrant.
We can use.
That is a combination. You give for hormone receptor.
In case if you have given tamoxifen and patient is now still disease progressive, then along with CDK4/6 inhibitor, we will use fulvestrant.
We have to give. Okay. So, yeah, for this one, what was I asking? Yeah, mTOR inhibitor, somebody told. Okay. What are the trials for that?
Bolero.
Okay. Then anything else? I'm asking in specific.
Exenet trial na neratinib.
Okay, Exenet, neratinib. Anything else? Any other group of drugs?
Olympia. Braca.
What are PI3 inhibitors? PI3 inhibitors?
Inovostat.
Silip.
Yeah. Little alpelisib. Okay. What is the trial for that?
Innovatrial.
What?
पढ़ा तो था मैं भूल गया. Solar trial.
Yes.
Then yeah. So these are the. Other than this, you can use vincristine. Okay, all this in metastatic settings. Okay. So.
मैम अभी नया ट्रायल आया है Destiny.
Yeah.
For triple positive, if triple positive or hormonal positive not responding to any drug, then we will see HER2 low, or if HER2 low is present, then we can use HER2 blockers.
Okay. So if you do, tell me some trials of using HER2 in neoadjuvant setting and adjuvant setting.
So, like first metastatic for metastatic Cleopatra, then neoadjuvant is that our neosphere, triphenna, adjuvant is affinity, PCR is there.
Noah, okay.
Catherine
Noah,
and
Catherine if residual disease is there.
Catherine is for what?
Residual disease after NACT.
Is it for Herceptin?
Yeah, her too, yes, ma'am. Because her is there, na? In Catherine, HER is there. It is for her.
So, no, it is about HER2 receptor only. Is it for Herceptin? What is for TDM1?
TDX, it is for TDX.
What is for TDX? What is for TDM1? What is for capecitabine?
capecitabine createx.
Capecitabine is createx as well as
That
this.
is in TNBC setting, right?
Yeah.
Incomplete.
And
Pathological complete.
TDX is destiny.
TDX is in
Destiny.
Destiny.
Catherine.
Yes. Deruxtecan.
TDM1 is for destiny, I think.
No, reverse.
Reverse.
TDX is deruxtecan is destiny.
Okay.
Okay, if it is HER2 incomplete response, what is the next line of treatment?
TDM1.
TDM1.
If that is not responding,
Exinate.
If HR positive, then
Exinate.
neratinib.
Niraparib.
if it is only HER2,
Only HER2, then
it's not available in India. Okay, trastuzumab government. Okay.
Okay.
So then yeah. So this is about you didn't tell me. You told me Noah. You told me this one neosphere.
Pure
Adjuvant में क्या है?
affinity. And Catherine.
Lepatinib का क्या है trial? Neoadjuvant.
Lepatinib, I don't remember.
अवनीत
What
कहाँ
is
गई?
Noah?
अवनीत ने सब ट्रायल्स पढ़ाए थे.
Lepatinib याद नहीं आया.
Nova is for Herceptin, no?
Noah is for Herceptin. What is for Lepatinib?
HER2 climb.
What is Hera? What is Pinher?
Hera trial is for HER2.
Sorry.
Hera trial is for HER2, ma'am.
Yeah.
But it is
What is
for
the combination of Lepatinib and
stomach.
Sorry.
Stomach.
Stomach.
I think for stomach
Hera
cancer.
is for breast only.
Breast.
Hera is for breast.
Hera is for breast. HER2 climb was for Lepatinib for brain mets.
No, I'm not asking like there is one trial which is for Lepatinib and Herceptin.
Oh, that is Hera trial.
Hera, Finher, Noah, okay, Neosphere, okay. In adjuvant setting, it is Trifina,
Affinity.
Affinity, and
Catherine.
okay, Catherine. That isn't it. Okay, TDX. And Lepatinib का मुझे याद नहीं आ रहा है. But I'll tell you. Okay, next class I will tell you. Then what about neoadjuvant period? Okay, this targeted agents. Okay, now okay, should we stop or it's 11:10? Okay, we'll discuss about BCS, MRM trials, SLNB, how to do SLNB, dual versus ICG versus methylene blue only. What are the side effects? What is the mode of injection? And the radiation and hormonal therapy with that soft X trials and all. In other
Ma'am,
class.
we will do class Friday, Saturday both, kya?
Saturday we'll do. Sunday my dad's birthday, so I can. Saturday we can do.
Friday, tomorrow.
Friday we'll do. Friday you present CS stomach, no?
Actually, I'm thinking if Saturday we will do class, then I will present on Saturday, and Avneet tomorrow bone tumor she will present.
Avneet will present tomorrow.
Avneet,
you will present tomorrow.
Yes, ma'am, I can present tomorrow.
Bone tumor, right?
Saturday I will present CS stomach, so I will get one day to read stomach. Today my larynx chapter over.
How was it? How did it go?
I am not sure because they asked very less questions. So everybody said कि it's good, but मेरे को वैसा feel good नहीं आया.
It's okay. We don't need to know everything. We are not ENT background, no. So we need to know only basic. If you have presented larynx, I think that's more than enough for exam. Okay. So nothing more. They won't ask larynx that much time. Generally, I mean, you won't get unless they're very sadistic.